Started. Welcome to our loyal members of the public. Thank you for coming. Apologies if there was some inefficiency in posting the location of this meeting. We'll try and make sure that's done much sooner in future, so apologies for that. But you're very welcome, and as we all know, we've still got to respect the COVID regulations, but I think these are that once we are seated, we're sufficiently spaced and there's good ventilation, so we don't need to wear masks once we're seated. Okay, I've got two apologies for the meeting this morning, both as a result of not being entirely well. So that's Vanessa Wood from the non-executives and Sally Shaw, Director of Social Care. Although I believe they may be watching on the broadcast, so hello both of them. We've got the usual report on directors' interest. Has anybody got anything they want to add or change? Okay, thank you. And then we've got the matters arising and the action log. Now, all of these are noted as being green here. I know that Teresa is going to pick up about MCALs. I was just slightly interested, Barbara, that there didn't seem much interest in having a creche service.
Only a few people have expressed interest, yeah.
Okay. And how did we ask people?
There's been, I asked the team who've done the sessions of listening to staff and what they wanted, and also talking to registrations and inspections with regard to what people had expressed an interest in.
Okay.
We have had in the past people express an interest. I think it comes in waves, to be
Yeah,
honest.
sure. Well, I'm sure it's a numbers thing, isn't it?
Yeah.
Really? Yeah.
So the Bradden Community Hub that's in development at the moment is building a nursery within its facility.
I see.
So I think that's probably an opportunity for us to, once
Okay.
we've got a firmer date for that development to conclude, that we then look at how we can work some magic with them, hopefully.
Okay, thanks, Barbara.
Yeah.
And then just for the members of the public, you know that we like to have some sort of patient story at this meeting. And the one that is scheduled for this particular meeting, the individual concerned did not want to be identified in any way, so has requested that the patient story comes in the private part of the board meeting, and we've accepted that request. But in future it will be the intention to bring stories to the public part, anonymised as necessary. Okay, does anybody want to notify any other items of business that aren't on the agenda? No, good. So if we can hand over to Teresa to take us through the Corporate Risk Register and Board Assurance Framework.
Thank you, Chair. So the Corporate Risk Register and Board Assurance Framework.
Sorry, apologies. I've been a bad chairman. The minutes of the meeting. Beg your pardon. Sorry, I just realised. Minutes of the meeting in September. Can I just check that people are happy that these are an accurate record? Anybody got anything they want to put right in those?
No, thank you.
Okay, right. As you were. Sorry.
Okay, thank you. So the Corporate Risk Register and Board Assurance Frameworks identifies the key strategic risks for Manx care, which links back to our broader strategic objectives around patient safety, culture and finance. So there is a significant amount of detail in these documents. You will see that for every strategic risk there is an executive owner who will be responsible for completing and updating that risk and bringing it to the board. And also there is a lead subcommittee of the board which will have strong oversight on this. So just working through the risks, the key strategic risks as it's currently seen is that Manx Care does not provide safe services and continues to improve quality, so that's a strategic risk. That's what we spend quite a lot of our time at the board discussing, how we continuously improve the quality of the services that we deliver. And that cuts across both health services and social care services. There's a risk that we don't put sufficient time and energy into improving the culture of our organisation, and also to maintain our financial controls and controls over expenditure. One of our key strategic risks is that we fail to achieve our data and digital transformation programme, and I think we've talked a lot at this board around the importance of that programme of work. And we've also talked about the importance of our relationship with all of our stakeholders, both the DHSC in terms of our delivery of the mandate, but also those wider partnerships. So our strategic partnerships with our colleagues in the UK NHS, who we work with for tertiary services, but also voluntary and community sector partners who are a really important part of our delivery model for the island. Estates is hugely important, and there's a recognise that we have strategic oversight of our estates and capital programme, and there's a paper on the board here today giving an update on where we are against our capital programme. And then we have also talked at this board around the failure to protect young vulnerable people from criminal activity and sexual exploitation, recognising there's a huge amount of partnership work going on in that space. The first 6 of these strategic risks are all part of the transformation programme led by Cabinet Office, so we are linked into those wider programmes of work. The Director of Nursing has developed a 10-point plan in conjunction with the Cabinet Office Transformation Programme around improving quality governance. We've got the Digital Oversight Group and the start of 2 new advisory boards on both information governance and the Manx Care Records starting in December. And obviously the Workforce and Culture Programme, plus the work on finance in terms of understanding the financial structure and how we move towards a 3-year funding model for Manx Care. So this is the first time we have brought the BAF in this level of detail to the board. I think it is an iterative document. It will need continually refining. What I would propose, Chair, is that we programme deep dives into each of these strategic risks to come back to the board. So as well as having the overview over all of the risks, we do a particular deep dive into each one of the strategic risks at each board and put that programme together. So either myself or the individual risk owner for each of the strategic risks will take any questions if there are any.
I just have one comment actually, which is the thing you have assigned Paul to the social services and Sally to the nursing.
Slightly the wrong error.
I think that's a really simple kind of error of formatting.
Yeah, I think
Yeah.
so.
The detail in the report has been
Yeah,
attended
yeah,
to.
that's absolutely fine otherwise.
Well spotted, Andy. Yes, sorry, Kate.
Sorry, Andrew. Andrews, could you just comment on how the risks are embodied in your day-to-day work? So how do they link to everybody's behaviours in day-to-day activity?
Okay. I think what we aim to see is a complete thread going right down from the service lines right through to the care group oversight, right through to the subcommittees of the Executive Management Committee and up to the board. Certainly, if we took the performance and accountability reviews as an example, we pick these strategic risks to particularly discuss. So, for example, when we met with all of the care groups a couple of weeks ago to do their performance and accountability reviews, we focused on finance. So we did that deep dive into an area of scrutiny. You know, we have an hour and a half with the care group, so we can't cover all of these, but then we have times when we talk about quality particularly. But these do align back to each of the subgroups of EMC. So under the Executive Management Committee, we have a quality and safety group for care, a quality and safety group for health. We have a non-clinical quality group, which Barbara chairs, which is dealing with the estates and the infrastructure, things like digital. So, you know, I think we can absolutely map through where each of these strategic risks get discussed, both at board level, sub-board level, at Executive Management Committee, at care group level and at service level.
I think in addition to that, when we were first creating this, we talked about having a risk scoring approach whereby individual divisions and care groups would have their own risk registers and risks that scored at the top end for say 3 months in a row would be escalated upwards, either via the relevant committee or ultimately to the board. And you know, these ones aren't scored yet. So I think that would be the next layer of this process, so that you can see that the risk process works from bottom to top of the organisation.
Yes, yeah. And we do have the Executive Management Committee, which meets every month, which does look at every risk which is rated at 16 or above.
Yep.
So that's sort of the threshold for where we have that scrutiny with executive leadership.
Okay, I think we are. I mean, this is just the start of the journey. This is the first time we've had the register, but it's that's.
I'd be happy to take suggestions about which strategic risk we would like to focus the first deep dive on. If there are any suggestions about where we would want to focus our efforts for the January meeting.
Sure. Well, there's one or two candidates, aren't there? Waiting times, for example.
Yeah, I would perhaps like to suggest, and I'm looking at the Director of Nursing, that we focus on quality and safety, because there has been an excellent piece of work done very recently to produce a 10-point plan around improving quality and safety, and I think it would be really strong assurance for the board to have oversight of that at the end of January.
Yep, that would be good to start with that. Yep.
Happy to do that.
Okay, everybody's happy with that. Good, thank you. Okay, so moving on, you've got my brief report reminding us that this is the third public meeting. Also, just giving a bit of update on some of the visits that I have managed to do. It is really quite a pleasure to get out and about and see places and people. And I am finding that everywhere you go, people have got their own pressures, pressure of work, pressure of expectation, but equally I'm getting a sense of feeling that things are at least inching in the right direction. I wouldn't like to overclaim, but inching in the right direction. So that's good to see. And then, of course, just recognising the fact that we've now got a completely new ministerial team who we have met once. And also, Teresa and I held an event a couple of weeks ago for all of the newly appointed MHKs, which was actually very well attended, for them to just come along and ask us any questions. And I think the main topic of conversation was how they work with us, and getting away from the old style of working where constituent goes to MHK, MHK rings up a clinician at random inside Manx Care and tries to get something done, which is really not a fair way of doing things. So now we've got MCALs in place, which I know Teresa is going to update on, and we've also got an established mechanism that MHK should raise their concerns via Teresa, which just generally seems to be working much better now. I think I'm not aware of cases of individual members of staff being rung up by MHKs being asked about things. I don't know if there have been any.
I think it has bedded down exceptionally well, and the new administration team have been very positive in endorsing the MCAL's approach as being the first line of communication, which is I think helpful for all concerned. Yeah,
it's best for all really, because that way they know that they're going to get a guaranteed response in a short period of time, and we know that the system is working consistently and not just for certain individuals getting a more intense service than others. Okay, so that's the end of my report. I'll hand you over to Teresa for her report.
Okay, thank you, Chairman. So there's just a few things that I wanted just to particularly pull out from the Chief Executive report this time. In terms of the COVID numbers, it's been relatively stable throughout the latter period of October and into November. But we are still operating with a dedicated COVID ward. We have also updated our COVID escalation and business continuity plan, and that will come to the Executive Management Committee on Friday of this week. I think in this particular iteration of the document, we've had to be much more realistic about our ability to open up additional capacity. So our previous plan did absolutely consider a much larger intensive care footprint and opening additional ward capacity. On assessment, our staffing levels do not allow us to open up additional wards in the same way as what the previous COVID escalation plan. So we've had to scale that back be much more realistic, but then also look at the other opportunities for reducing admittance to hospital by using things like the ambulatory care model, same-day emergency care, and all of those initiatives which really support people to remain in the community if at all possible, or at least have hospital care which doesn't require admission to hospital. So we are able to treat and discharge people same day or only with a short length of stay. You will have also seen that I've produced a YouTube video. We've moved over to describe our escalation and pressures using a standard OPAL framework, operational pressures and escalation levels, which aligns with the approach of all hospitals in the UK. I think it's a very consistent way of describing pressures and describing the actions that the organisation and the wider system need to take when we're in pressure. And I think we have also started to be much more transparent with the public about the pressures that we are experiencing, and using that as an opportunity to remind the public of the alternatives that exist, rather than necessarily coming to the emergency department. And that's something we will commit to doing over winter. Our next stage is to describe all of Manx care services using the OPAL framework and use that consistent language so everyone is clear about the operating pressures. Just coming on to the MCAL service, I think we have recognised the real value of this service. They are achieving very good turnaround and response times, very high patient satisfaction. We always anticipated that we would continue this service, and so the business case to put that service in place substantively is currently going through business case review group. It will be supported by a leader who would be a band 7, supported by 2 executive officers. So quite a similar staffing structure to what's already in place. That is working well, and then we will start to build out using voluntary and community sector and linking with other partners to build that service. But I think it's a recognition of a service which has been incredibly successful in the short time since it started. I just wanted to also recognise that we have appointed 2 new clinical directors since the last meetings. Dr. Marina Hudson has been appointed as the clinical director for integrated mental health services, and Dr. Pradeep Thacker, the clinical director for integrated women's, children's and family services. I also would like to recognise that we have had some very successful consultant appointments during late October and early November. So we've appointed 3 consultants in respiratory medicine. We've appointed a consultant, a radiologist, general radiologist. Unfortunately, we were not successful in appointing to the breast radiology post that we had advertised. And we also have appointed a consultant anaesthetist, and yesterday we appointed a consultant geriatrician. So it is positive that we are able to attract and recruit into some of our consultant posts. The paper is supported by a report from CHS, who have been working with the organisation since the beginning of October, and they are helping us to support flow through the hospital, looking particularly at the SAFER bundle around how we look at discharge planning at ward level, supporting dialogue with patients and with their families, and ensuring that we are trying to reduce our length of stay and reduce our delayed transfers of care. So there's an initial report from CHS as part of the pack. Also as part of the pack is some of the priority actions that we've agreed with OHR, our Human Resources Department, in terms of recruitment. So there's an action plan there which the executive team has signed off, which is about ensuring that we work with the Talent Acquisition Service and OHR around some priority actions for recruitment, which I'm sure the Director of HR will add to if needed. I think the Horizon scan really sort of demonstrates there's some really good work going on in all of our care groups. We've officially transferred the therapies service and podiatry service into the integrated primary care and community care group, and I think that gives strength to that function and also starts to build on the primary care at scale model. We're working in partnership with Hull University for placements for Year 5 Doctorate of Psychology students. We have appointed a new head of the Isle of Man Ambulance Service, who is Will Bellamy, who joins us from January. And we have a nurse endoscopist, Nicola Burgess, who recently qualified. And I think these are all really positive developments around our workforce, being able to recruit some very high calibre individuals, but also doing developmental work and linking with other establishments to build our workforce and to provide training, education and development opportunities. So I'll pause there. Sorry, there was a lot in my report, but I'm happy to take any questions.
Good. Okay, well, in the order I saw Nigel first.
Thanks, Andrew. Through you, yes. Teresa, a very comprehensive report, thanks. It was just something I picked up in item 2.5 of your report at the end relating to the work of the Executive Management Committee. EMC noted continued concerns from operational teams regarding non-funding of NICE-TA, National Institute for Healthcare and Excellence. I'm beginning to get the acronyms. While this is anticipated to be partially addressed in the future, there's evidence that some consultants are now referring patients to the UK for treatment. So I'd just like to understand a little bit of context around that, because clearly it has, I guess, clinical outcome issues, and it also has cost outcome issues. And as I understand it, I know there is a plan in place to have the cavalry on the hill as far as NICE-TA drugs are concerned.
Yeah.
I'd just like to understand a little bit more about that, because it seems that folk are maybe voting with their feet and going around the back door a little bit.
Yes, and I probably would encourage our medical director to also give comment on this. Yes, we know it is a huge source of concern and contention to our clinical staff. If they know it, there is an evidence-based best practice treatment available, they would absolutely want to be able to prescribe and give that treatment. And currently our funding arrangement does not allow that. It has the ability for the organisation to really compromise some of the work we're doing to build those strategic partnerships. So, for example, the Clatterbridge at Nobles model, if we cannot prescribe the same drugs as what Clatterbridge use in their formulary, that really compromises our patients, and that ability for the governance that we're working to in that model to have the level of integrity that we need it to have. And potentially it does leave clinicians with a very difficult decision of not prescribing something which they feel would be hugely beneficial for their patient, or the alternative to get around that is to transfer that patient for their treatment in the UK, which would then incur costs. Now, what we don't understand at this point is exactly how many patients are being referred to the UK in order to get the NICE treatments that we are not able to prescribe here. That's a piece of work we need to do. But I have to acknowledge it's something we've all flagged as a huge risk, both at patient level in terms of that clinical buy-in, plus also for our strategic partnerships with the North West as we want to really develop them and get that integrated governance approach with them. But I'm hopeful that there is a solution coming forward. But I think it is important with finance colleagues and with clinical colleagues, we quantify, because actually that will help create the evidence for the business case that we fund this, because we're probably spending, or we could be spending equivalent amount of money by transferring these patients to the UK. And we know from the finance reports we are significantly overspent on the tertiary budget currently.
Sri, do you want to add at all?
Yeah, just wanted to add, I think, Teresa, your answer was comprehensive. I think just to go back at, when NICE evaluates a drug for a patient treatment, it evaluates both economic and clinical value in it. So there's actually no point in duplicating in the Isle of Man to actually say that it is economically valuable and not valuable, because it's already gone through that process. Not every single patient who is eligible for a NICE-TA drug don't automatically not get it here. There are pathways that's beyond where we are placed at the moment that people do get it, but there are certain number of patients who do not get the NICE-TA drugs. I believe that we are working in partnership with DHSC and other colleagues to see how we're going to fund this. And this has been a long-standing battle with how we're going to get to the point where all our patients or all our population here will get all what is recommended in UK as well. So I think it's an ongoing thing, and it's moving kind of. I can't assure the board at the moment that it is at what point of time next year this is going to be approved. And even if it does get approved, we know that it is not automatically going to be all the nice TA drugs at once on one fine day. It will be a gradual kind of progression, but I'm not able to kind of tell you what time and what date it's that going to be.
Okay.
I'm very glad it's on the table. Thank you.
Okay, thank you. Andy, you're next.
Thanks. I actually had two questions on Teresa's report and one on the CHA report. I'm sorry that might take a couple of minutes, but firstly, my first point was actually related to Nigel has stated, but it's the slightly more fundamental level, which is, are all of our consultants acting in common in terms of transferring patients where a nice TA drug may be the appropriate route, or are we denying a quality of access to some of our patients as a result because of differences in practice? And I think that it's the quality of access I'm more interested in rather than the cost almost. And I think we need to be sure that whatever we're doing, that we're treating patients equally all the way across. So I don't know whether that's...
Should we take that one first? Can you answer that?
Would you mind, Tree?
Yeah, I think the clinical pathways that we brought around all conditions, the clinical leads are responsible for making sure that there is an access to the drug as such. Whereas your question is about the equality impact assessment, I like to think that there is no, I think there is no issues about the access to the TA drugs. Individual patients are accessed differently. There's no issue. I have not been made aware of any of that as such, but I'll be quite happy to kind of look into that and see whether we can bring it back to the board to see if there is a problem with that, if you've been aware of it. But as far as I'm aware, clinical leads, clinicians are not currently, haven't said anything about the access. The pathways are clear. The NICE clearly recommends eligibility criteria for every patient of what drug and when it is needed to happen. So it is just a bit of a matching up the criteria itself. So apart from that, I didn't see any gaps in access at the moment.
Teresa, on the same point?
Yeah, I think it is just that broader. I know exactly where you're heading with this, Andy, and I think there is a broader issue here that not all of our patients will be able or want to travel or be in a position to leave their families to go and access care in the UK. And I think we have to acknowledge that when we've offered choice, even if it means travelling and coming back the same day, there are some of our patients who just feel that is not, they're not able to take advantage of that. And I think we've got to be really mindful when we're planning our services for the future and potentially offering choice, that we have taken all those considerations around travel and support into account when we do that impact assessment, so we don't end up with those people who are willing, able and have home circumstances to be able to travel, and those that don't, because that will sort of create further inequity in our system. So I think it's absolutely something we need to have at the forefront of our mind as we strategically plan our services into next year.
Yeah, I think that's all I was really asking, just
Yeah.
to keep bearing it in mind. There was nothing specific, Shri. I wasn't aware of anything, but I just want to make sure that we're not worsening the situation.
Yeah.
So fine, thank you. So my other point, sorry, was for you, Teresa, which was about you talk about communication to the public about winter pressures. We obviously had the recent issue where ED was so crowded that we were asking people to go to Ramsey.
Mm-hmm.
That's not desirable for a lot when the concentration of people is in the south of the island, particularly around the Douglas area. I just wonder whether more frequent communication and nudging just to remind people. So I think it's the nudging part to say, look, just be sensible about these things, to try and ease some of those before they happen, so that we don't land up in the situation of having to send people probably in the least able to travel to Ramsey. I'm going to get them to travel to Ramsey.
Yeah.
And
Yeah.
I think I think it's just maybe more of an elbow rather than anything else. And
Yeah.
I'm very keen on the idea of that we use nudging more often.
I think it is, and I think we need to continue, and it is part of our plans to build the out-of-hospital offers to ensure the public understand what the community hubs can provide and what services are available as an alternative. You know, we do need to absolutely keep reminding, particularly as we're building those services.
Yeah.
So there's new offers available all the time. You know, what I do need to say is just make it really, really clear that even when we're operating under severe pressure, the whole reason behind the Opal framework is to make sure we are operating safely.
Absolutely.
So we have really, really clear actions, and whilst we are under pressure, we have a full capacity protocol in place which describes all the actions we take when our emergency department is full, and we can move patients through the system safely. But I do think it is about having that open dialogue with the public, so they understand when we talk about those sorts of pressures what we mean. It means we are absolutely taking the care and safety of our patients paramount, and we are putting additional resourcing and senior people into those situations to manage that as effectively as we can. So the point of describing that is to provide assurance to the public that we absolutely know when we're under pressure and we know the actions we take in response to that.
Okay, thank you very much. And my last point is a very simple one about the CHA report. In the number of referrals by outcome to the MTD, effectively it's saying home without package of care. I wasn't clear whether that was a group of people that needed a care package in place, but it wasn't available, or they just simply didn't need it.
They didn't need it.
Okay.
They'd been assessed as not needing
I think
to.
maybe the labelling, because it's easy to mistake that. I think perhaps a slight change in the labelling just to make it clear they really didn't need it.
Home
Yeah.
not
Especially
needed
when they put the
packaging.
bar in amber
Yeah.
as well,
No.
which kind of makes me
Point
nervous.
No, that's a good point.
Yeah,
That's a good
thank
point.
you. Can I make a final point?
You can. When you say final point, Sarah wants to ask a
Oh,
question.
okay, sorry.
Do you want to?
Thank you. Just two questions and then a comment from me. About MCALs, Teresa, when we had the presentation at the last board meeting, there was some concerns raised about losing staff in advance of us giving assurance that they would maintain their jobs. So it was just a question about whether that was still a concern, or whether actually by moving this forward a little bit we're in a position where we know that won't happen. And then my second comment was about really, really brilliant to hear about the appointment of the clinical directors. And just wondering whether at some point the board might meet the clinical directors as a group. I think that might be very helpful for us, and hopefully demonstrates our support for them. And then my final comment was just, I was very delighted to hear yesterday about the Mask Up campaign that the communications team have been running, and the success of that. And I think as we go into winter pressures, that's such an important aspect. And for those of us that have come across, I think we have noted an increase in mask wearing on the island, and that's been a really positive thing. So just to thank the team for the work that they've done there.
Yeah, thank you. And just to come back to your first question on MCALs,
Thank you.
yes, we are have provided the level of security needed to the staff who are supporting that service currently. There will be some changes because people have set the service up, and some people do want to go back to their substantive roles. But yeah, those people who want to continue working in MCALs have the opportunity to do so. No, absolutely not.
Thank you.
No.
Thank you.
And just the point about meeting clinical directors at some point, I think it would be good to arrange that.
Yes, we
Sure,
can get that sorted. I think they would very much welcome that opportunity as well.
Thanks.
And you want to change
I want to just make a final point because I should have mentioned this, but DHSC Manx Care did win the Public Sector Achievement of the Year award for Isle of Man Newspaper Awards for Excellence, which was held last Thursday evening. So it was a really lovely evening. Our Director of Operations and Emma Cleater, who's our community matron, accepted the award on behalf of DHSC Manx Care, and it was a lovely evening of celebration. So I just didn't want to not acknowledge that in my report.
Very good. Well done, and well done, Oliver. Have you got? Did you have a nice trophy or what?
I should have brought it, but it's in my office.
Okay. We'll have a trophy cabinet set.
Yes.
Good. Okay. Any more questions for Teresa? Yes, Nigel.
Just one comment really, Andrew, and that's just to say to the team, very well done on the recent recruitment initiative that went out in the local papers for those of us who live on the island. Fantastic insert in the local newspapers about the benefits of working in healthcare and the benefits of living on the island generally. And you know, as we emerge from this dreadful period, I really do think that there will be opportunities arising where we can spread the word of what a great place this is to live and work,
Sure.
and have people banging on the door to get in rather than us having to drag them over here.
Yeah.
And Andrew, can I just build on Nigel's point while we've got the opportunity? So I know that this is being broadcast. Tomorrow evening we have an open day for anybody who's interested in becoming a nurse on the Isle of Man. We have an open day. Please do come along. It's open to everybody who's got an interest. If you're interested, come and see us and we'll help you develop your career pathway towards becoming a nurse on the Isle of Man.
Good to use the board as an advertisement. Well done. Okay, Katie, yes?
And just to add to what Teresa was saying earlier about appointments, I was on the panel that appointed the geriatric consultant yesterday, and that came about because a member of staff within Manx Care was actively talking to an old pal of his from across and saying, why don't you come and join us? And so the word is getting out, you know, so that was really gratifying to see.
Yes, well spotted. And I'm particularly keen that we do this in primary care as well, where our GPs here are under a huge amount of pressure at the moment with workload and shortages. And the UK environment is difficult for GPs. It may well be that there would be people who would see the Isle of Man as being a very attractive alternative. So I think we need, I know that we are working on a recruitment package for GPs as well, and we need to give them just as much support. Right, okay, I think that's it for your report. So moving on to committee chairs. Now, as I said before, Vanessa isn't with us this morning, except perhaps watching. So I think Sarah and Paul are going to take the quality, safety and engagement one.
Shall I start, Sarah? Would that be okay? So on Vanessa's behalf, I would invite the board to take the papers read. If I can just highlight a few important assurances for the board. The committee's programme of work is now starting to bed in, and we have a 12-month schedule of work that will ensure the committee touches on the most important assurances that are needed on safety and quality. So we're about 3 months into that journey now, and it's starting to surface things that the committee are looking at in detail. And some of those are referred to here. So, for example, we know there's an enormous amount of work taking place on theatre improvements at the moment, in particular with an emphasis on safety and quality. And the committee expressed an interest in receiving assurances on the programme, the delivery of that programme, so that it can be satisfied that progress is being made and that outcomes are being sustained. So we're going to take action to build that in, probably from next month actually, so that we've got that degree of visibility. So that's taking shape really well. There was a very good piece of work done in social care where there was like an amnesty of external reviews that have been undertaken in the past and a stock take on the actions being taken to respond to the recommendations that have been made. And the committee received quite a good assurance actually that there's progress being made against all those actions. And I thought it was a very bold piece of work for the team to do. It led to a conversation around which other sources of external assurance the committee might feel it could get some benefit from, particularly in relation to the Independent Review Board from complaints. And we're going to look at how we might weave that in to help build that intelligence in the round around things that the external world can see around the way care is delivered in Manx Care. So I think that's the start of a very interesting and important piece of work for us. And as you know, the committee pay very close attention to infection prevention and control. We look at that every single month, and we go into detail. There are some concerns around the standard of hand hygiene practices, particularly in relation to compliance with that. We're doing some focused work to understand why that is a difficulty for us at Manx Care. But to balance against that, we've got pretty good outcomes for hospital-acquired infections in relation to MRSA and Clostridium difficile in particular, they appear to be under a good degree of control, which is very encouraging. That led into a conversation that we may need to bring back to the board in due course around trajectories for compliance going forward, particularly in relation to Clostridium difficile infections, where the board has a target of 0, and it's not really a realistic target to achieve, but we can have a conversation around what might be a reasonable threshold for compliance going forward. We did surface an issue with something called CAS alerts, and for the benefit of those who don't know what they are, they're like instructions that you receive from manufacturers of medical devices or from regulators, and they generally ask you to take some action because there's an urgent need to do so. So an example might be that they've asked us to withdraw a product from our shelves or from operational use because there's an issue with the batch. Or in some cases they ask us to take action because learning has been found elsewhere in the health system and they want us to make some changes. I've been asking some questions since I've started here about what assurance have we got in Manx Care that we have responded to those alerts in a timely way. And I think it's helpful that we've found that we don't have a great deal of assurance that we can look back on. It's helpful insofar as I'm going to take action to deal with that, so that we're in a much stronger position as a board, and the Quality Committee in particular will be confident that when alerts come into Manx Care, we can demonstrate that we've responded to them in the appropriate timescale. So we've got two different systems operating that I need to merge together and then drive that forward. So there is work ongoing with that. It's been a topic of conversation, I think, it's fair to say, Sarah, for a number of meetings now about mandatory training being a concern. I do have some concerns about both the control and the design of the mandatory training framework, in addition to concerns around the level of completion. So there's a fairly big project that will be needed, which we've included in what we're calling the Governance Development Roadmap. In concert with the transformation team, we think there's a project needed to strengthen our mandatory training arrangements and the assurance against those core subjects. So I don't want to say any more on that at the moment, because I think it's quite a project really to pull off. But suffice to say, I think the committee are cited on that as an issue for them, and they will be monitoring that closely as they go forward. And then just finally, on a positive note, we have previously reported to the committee about a concern around the timeliness of vital sign measurements, how quickly we respond to them. And we did take action upon becoming aware of an issue with that. And we were able to deliver to the committee some very positive assurance that, particularly in September and October, substantial improvement had been made with the timeliness. And I think the most important point about that is it shows that Manx Care and the staff in Manx Care are responsive. And with a bit of help and a bit of guidance, they will do the right thing for patients. And I was hugely encouraged by that. And as I sit here today, that progress has continued into November as well. So I think that's a really positive point. And if I can give way to Sarah, if there's anything I've missed, or perhaps Nigel, who were also at the meeting, if there's anything I've missed.
No, I don't have anything to add.
Can I give you a question? Because I mean, talking about quality and safety, I think one of the most powerful ways of ensuring this is through measures. And you pointed out yourself, and the integrated performance report shows that we measure MRSA, C. diff, hospital-acquired pressure ulcers, medication errors, falls, and so on. And indeed, the figures are all encouraging. So my question is, how can you be assured that those figures are accurate and that we are properly recording everything that happens?
So there's a number of things I would like to say in response, I think, to your question. I'm not sure at Manx Care, I don't think we're in a position at this point in time to be able to say exactly where we stand on quality and safety. We're building the measures that we need in order to evaluate that. For the measures that we've got, we will test the accuracy and the validity of the data against the systems that we've got. I think what that has shown against a number of measures, Andrew, is that there's low confidence at the moment in the quality of some of the data that we rely on, but it's all that we have at the moment in order to make some judgments. So to take that forward, we are building a quality and safety dashboard, which is probably about 80% of the way there. It's just a final push to go with that. That will orientate our measures around the key lines of inquiry. So we'll have a set of measures for safe care, a set of measures for effectiveness, caring, responsiveness, and well-led. And that will, in some cases, that will demonstrate that our care actually is quite good, particularly in relation to harmful falls per 1,000 occupied bed days. The exposure to that risk in Manx care is much lower than one might expect to see in an acute setting. I think that's really encouraging. In some other respects, we've got no information that we need to try and source and build in, so that as a board we have that full and complete picture of safety. I think we probably by the end of December will have something that we can work with, and I think that will then flesh out where we have some issues with data quality. I do believe that we will have some issues with data quality, but to surface them and then have a plan around how we assure that and respond to that is something that we will do going forward. But I think we need to keep a very close eye on that.
Thank you. That's very encouraging. Okay, I think we're time to move on to the next committee, which is Finance Planning Commissioning. Nigel.
Thanks, Andrew. Yeah, Finance Performance Commissioning Committee met just over a week ago, and as ever, it was a lively and robust meeting. I think it was ever thus with finance and performance. But we received excellent papers on capital projects, high cost secure mental funding, and indeed contract compliance, which is a massive subject in itself. We're very also pleased to receive, as promised and on time, the first iteration of a digital dashboard style information and performance report across all the care groups. I mean, clearly this is an iterative document, but it's absolutely moving in the right direction, and we were very pleased to see the quality of that and the consistency of the way in which this report has been put together. So congratulations to that team as well. Large discussion around the feedback from the execs' performance and accountability review groups, and some suggested actions arising from some emerging trends. And a very comprehensive update was also provided on the progress of the restoration and recovery project, where we're playing catch-up, and I felt that was very encouraging to do. And I think it was very heartening to report that this massive undertaking is clearly making good and substantive progress. I think as well what I'd really like to say is that the quality of the reporting that we're getting is really very good. I mean, I've been around the block a few times and for a number of years, and I'd just like to say that the quality of feedback that this committee is getting is really very good, and I think congratulations to those individuals for that, operating in difficult and challenging times. Majority of the meeting, quite rightly, was deliberately devoted to discussing the current management accounts of the service, you know, where tensions and pressures still and will persist. You know, substantive time was devoted to our back to balance plans, also progressing the cost improvement plans, and clearly seeking to understand and highlight any material variances from our plan, you know, with the emphasis on controllable expenses versus non-controllable. And also a response to a query document from the department and more particularly the previous minister. So a lot of work in your committee, and a number of those issues have obviously been escalated to today, as you'd expect. Also in the period, I attended, along with Teresa and a number of other colleagues, an SLA, a service level agreement meeting with Treasury, which was immensely helpful, which is where we were looking at the work that Treasury perform on behalf of Manx Care. And I felt that the individuals and the dialogue that we're able to have there was immensely helpful, particularly in terms of speed of reporting and banging on about monthly accounts as opposed to some slightly outdated accounts. And particularly a piece of work which might seem small but I thought was very important, and that was around control of purchase invoicing in the system. And this is absolutely key because clearly it's where costs are incepted. And there's a really interesting and useful piece of work beginning around that, and we're in complete alignment with Treasury about how we go about that. So, yeah, big meeting, but very positive.
Thank you, Nigel. Okay, I think we'll come back to finance later on in the agenda. So People Committee, Sarah.
Thank you. I'll take the report as read. I think, you know, the key issues for us in terms of the business of the committee were around the discussion of pay negotiations, around mandatory vaccination and about staff engagement. But I think the board can take assurance that those issues are being discussed at the right levels, and that there are some ideas around going into staff areas to engage with staff rather than asking staff to come out of their areas, and that had been trialled on a ward and had been very successful. Just two things that I would like to bring to the board's attention. The first is that there were many executive colleagues who were unable to attend the committee for exceptionally good reasons, and we did have a discussion about whether the appointment of a deputy to attend the meeting on behalf of the executive director may be a way forward to ensure that issues could be discussed and escalated as appropriate. And then the other thing is just to say that I'm absolutely delighted that we've got 16, I think that's right, I did just check and add them up again, nominations for the staff awards. So that's absolutely brilliant, and I'm really, really pleased about that. It's something that the board has talked about for a long time, and really thankful to colleagues who have come forward and nominated their colleagues. So that's great.
Thanks. So let's pick up two things arising from that. One was the having deputies representing. I mean, I think that's very normal, isn't it? So has anybody got any objection to that? So if an executive director can't attend a committee meeting, then really they should find a deputy to represent them, and therefore we would always be quorate.
Yeah, I would support that, and I always think it's very good development for the deputies to have exposure to board level committees.
Okay. So good. Let's regard that as agreed. And then you mentioned a discussion about the mandatory vaccination, which has now happened in the NHS. I don't know if I should ask you or Teresa, what's the plan to bring that to a conclusion, or is that really a matter for Manx Care, or is that a matter for DHSC?
I'll probably refer to Oliver, who sort of is our lead on the vaccination board, as to where those discussions are had, because actually I don't think it is purely for Manx Care to decide, and I think it's a wider discussion point across DHSC and the Cabinet Office. Oliver?
Well, it hasn't been explicitly discussed at our vaccine board, but I believe it is under discussion within the Council of Ministers at the moment, and I expect that that's going through the COVID response group that's been recently established.
Do you know what our vaccination rate is for staff?
For health and care staff, it's around 95-96%.
Very high. Yeah. Sure. Okay, and you don't know any time scale as to when there might be a view emerging on that?
No, I will find out though.
Okay, thanks.
If you want, Mr. Chairman, I'm sure we're prepared to give you them.
Well, how do you mean, sorry?
On this thorny subject.
Your views?
My views, I have very strong views on it.
Go on then.
I have
Fire away.
I don't think it should be mandatory.
Right.
Perhaps just give us a
Go on.
deeper understanding why you feel that way. I think, look, I'm not a clinician and I'm ill-educated in this area, but I think it borders on personal choice and it borders on education of the individual. And I think particularly when you have a very high group of people who have decided to be vaccinated, 95% is an incredibly high rate, I feel that we would cause massive alienation and massive concern, almost like a second-class citizen, if we made it mandatory. And I just feel very strongly about it individually. So.
Okay, I know some people feel very strongly the other way as well.
Yeah, absolutely.
It's not just a right to not be vaccinated, it's a right not to infect other people.
Just as a data point, and I'm not going to suggest which way I fall, but in England what's happened is, because it was mandated in care homes to start with, and there was a migration of care home staff to the NHS, because at that point it had not been mandated. And what's going to be interesting now to see is if they migrate again out, or whether they say, all right, it's a fair cop. But it'd be very interesting to see what happens. So.
I'd be very behind educating people.
Absolutely, that is a much better way on the whole. Yes, it is. Yeah.
Well, it's obviously a subject that inspires passions, so let's make sure we have an update on that for the next board meeting. Right, okay, moving on to the Data and Informatics group. Katie?
Yes, thank you. So the data has already been mentioned in a couple of the previous chairs' reports, and in fact Paul was saying how important it is to have accurate data. So we are quietly cheering our first iteration of the IPR that has elements of automation about it. However, the next thing is to make sure that it's accurate, because it's all well and good to automate these things, but then there has to be an element of validation, because you need to make sure that the data that's coming through is actually being inputted correctly in the first place. So whilst we are now progressing and starting to automate, that's fabulous, but there's now a body of work to make sure that what's being automated is actually sensible and it's not just complete guff. So that's going on, but we are quietly victorious that we have started getting some elements of the integrated performance report automated, so that's great news. The other area of data validation is going on in clinical coding. So people will be aware that we've had a clinical coding exercise going on for some months now, and the same thing applies. Now that we're getting to the stage where we've got a body of data that has been clinically coded, what we now need to make sure is that how that work has been done has been well thought through and accurate and so on. So two pieces of data validation going on, which I think are very key in terms of the D&I committee. The other things in the project spaces, I'll take that as read. I don't think there's anything that necessarily needs to be brought out. But my major concern was that now that we're getting to the stage where we have levels of automation in place, let's just make sure, take a breath, let's check all the data is good, make sure there's no adjustments that need to be carried out, and then we'll press on after that. So that's my report, Chair.
Thank you. Don't seem to be any questions on that, so thank you for that. And then finally, Mental Health Act, which only took place yesterday, didn't it?
It did indeed. So very briefly, we had a fair bit of discussion around control and restraint policies and procedures to ensure that obviously we're completely compliant with the existing Act. And don't forget, this committee, its principal objective is to ensure compliance with the existing Act rather than to discuss changes to the Act, if you like, although that is a secondary objective. We also received clarification about the role of the associate hospital managers and the independence of reviews. Now, we'd previously talked about non-executive directors taking part in some of those reviews, but that it does make sense to retain the independence of those, in my view, to ensure that the patient is completely clear that there is no interference from the health body to which is providing the care in the first place. However, it was suggested that by twice each year that a non-executive director might attend as an observer only, just to provide the board with assurance, which I think is a very sensible notion. Finally, the other focus of the group is on Section 115 of our Mental Health Act, which is equivalent to Section 117 of the UK Act, which is around providing aftercare. So those people that have had their liberty removed for a period of time, they are entitled to support afterwards, but the problem is that is ill-defined in our Act, and the costs are not well defined. But we believe that we should be able to address that through regulation rather than changes to the Act, and we need that discussion focused and with the Attorney General's office to ensure that we can control that better. So that is ongoing. There is a Section 115 focus group which are about to meet and then provide the committee with an update, and then we can move that forward. Hopefully we can bring that into control and we can give the board assurance of control of costs around Section 115 over the next few months. That's about it.
Can I just ask one question, because I think I saw it on some earlier papers, about the name of the committee, the Mental Health Act Committee, and is it entirely focused on the Mental Health Act, or is it more broadly focused on mental health?
We actually had this query from the Mental Health Commission, and I think we needed to clarify. We should have clarified that actually is focused on compliance with the existing Act. That is our key focus here, to provide the board with assurance that we are compliant with our responsibilities and our obligations. So it may mean we should change the name of the committee a little, but I believe an explanation is due back to the chair of the Mental Health Commission, which we'll take care of over the next week or so.
Right. Okay, so that's the feedback from the various committees. Thanks again to all the committees for the scrutiny and detailed work that you do that would otherwise mean that our board meetings were about 10 hours long, so it's good that you do it in the committees. Okay, the next item, which is really for information, is the Our Island plan. Obviously we have a new administration here and they're setting out their vision for the island, but of course it is relevant that of the several chapters in here, there is one on health and care, health and well-being I should say, and perhaps not surprising, but if you look at page 9 of this report, it does set out a range of what it calls what we are doing, which includes implementing Sir Jonathan Michael's report, includes reducing waiting times, and includes the development of integrated health and care. So this is essentially reconfirming that this new administration buys into the picture that the previous administration was working for. And I'm pleased to see the commitment to improving access, because that will have to be backed up by some funding to make it happen. So, anybody want to make any comments about this report? Beautiful pictures, lovely shots of the island here. You go.
Sorry, first, no, please. One of the things which has been a constant bugbear on the island is around the support package. It is more economic for people to go to a nursing home rather than stay in their own home because of the way that our social security is skewed. And while it's a single line in here, I don't think actually that expresses enough just how significant that is. I think that should be pretty much at the top of the list of objectives here, because without that, it doesn't afford us sufficient control to help people in their own homes, which is ultimately the objective of integrated care, keeping people in the community where they belong and where they're probably happiest. So I just think maybe the ordering here isn't quite as I might have liked to see it.
Sure, well, it's a fair point indeed. Teresa?
Yeah, I think in terms of those very high-level objectives, there's absolutely nothing we would argue with. We absolutely do want to see better integrated healthcare, early intervention, a home-first approach, support based locally in communities where possible, and reducing waiting times. So I don't think there's anything. I think the devil is in the detail. You know, we haven't got a wealth of early interventions and non-statutory services underpinning our statutory services, and that is an area where we need to develop very, very quickly. I know we're all very focused on it, and it is a priority for Manx Care, but I think it would be foolish to underestimate just how much work is required in those spaces to develop the early help, and it doesn't happen without additional resourcing, because actually you cannot necessarily shift statutory funding into non-statutory early help and support very easily. So there is a need to pump prime. I think the other really important factor here, I would not want this to be seen, this is just a health agenda. There is a huge amount of multi-agency working in all of this space with our other government colleagues in order to deliver this agenda. So whilst I absolutely welcome the priorities, I would like to very quickly get to the point of understanding what this actually means in terms of resourcing, multi-agency working, and a clear implementation plan, which I would expect us to see through the mandate objectives through DHSC.
Sure, good point. Sarah?
So Teresa's partially answered my question, which was kind of the so what question. How does this fit with our mandate? How do we comment on it? How are we responding? Is there a mechanism for that? So that's my first question. And then my second question is just quite specific. So on the 4th bullet point, it talks about ensure appropriate provision of services and support is available to all victims. I don't really understand what that means. I mean, I understand what it means, but I don't know why it's particularly pulled out and why it's put in health and well-being. I wasn't aware that there were particular issues in that area. And I don't know what's meant by victims either. I think it's very vague. I suppose that's what I'm saying.
Yeah, yeah. And we know they are developing a domestic violence agenda. There is the work going on with the SARC, the Sexual Assault Referral Centre. So we know there are a number of pieces of work, really important pieces of work, of which Manx Care is involved in developing a comprehensive approach to some of those issues. And I can only suspect that's what it's referring to. But again, I think this is where you're quite right. We need to see the devil of the detail, and understand what the implementation plans look like and how this ultimately feeds through to the mandate objectives for Manx Care.
Because you could read that in so many different ways.
Absolutely.
Crime, cybercrime, domestic violence, anything. So I think, yes.
Yep. I think it's specifically in relation to the domestic violence bill, which is currently being discussed, and some of the ongoing work around sexual assault referral centres.
Thank you.
That would be my suggestion. But
yeah, sure.
If I cast my mind back probably about 18 months, there was for those who can probably remember, Ollie, you'll probably remember the joint needs assessment that went on about, there was a whole group of things, so it included domestic violence, sexual violence, FGM was included, for instance, and they were all listed, and there were a list of actions that were going to be taken by DHSC/Public Health. And I just don't think those have been developed yet. So I'd read that as it was that whole pot of all of those things that are identified in that list from the joint needs assessment.
But Sarah's absolutely right. The report is not explicit about what it means, and it could easily be misinterpreted. But
can I just comment on next steps as well?
You can. I think, yep.
Sorry.
Nigel, do you want to come in first? Then we'll...
Yes, I know. It's for you. I like the report. I thought, but it's a high-level positioning paper. It's not deemed to be a detailed thing. But what I liked about it was it seems to recognise that this is not any one subject in particular. It's not just about healthcare. It's about education. It's about aspiration. It's about communication. And I mean, that we're on a journey is not in doubt, and that we're probably on a 5, 10, 15, 20-year journey is not in doubt. But we are setting the scene and setting the foundations for health and integrated care on the Isle of Man for the next 50 years. And we're going to shoot the lights out and do it. And so we need to be aware that part of our role is geopolitical as well as actually delivering it, because we have views. So I'm encouraged, but I absolutely agree that the devil is in the detail.
Yeah.
And of course, at the end of the day, we're a high aspiration community and a low tax community. And we've got some work to do.
Okay.
Andrew, could I make a comment? I mean, I want to echo what Nigel's just said there. I am very encouraged by this plan. I recognise it's high level. If there's one comment that I think I would make is that I think the emphasis here is on ill health and response to ill health. If it's going to deliver, as Nigel says, this long-term future of health and well-being, I would hope and expect that we would put more emphasis into prevention and public health to offset the need for ill health responses.
Well, I think these are all useful bits of feedback, which we can pass through via our minister, can't we? So, thank you.
Yeah.
So, you wanted to say something about next steps?
Yes, so we are being asked to provide any formal feedback as a board on this document by the end of this week, which we can do from the discussions we've had today and any other comments people are prepared to share with me. And I have agreed with the Chief Exec of DHSC that we will start doing some work on what this means in terms of mandate objectives at a session that we're having with the executive team on the 7th of December, which will start to not co-produce but inform what could be the mandate objectives for Manx Care from next year.
One more comment, please. I'm sorry to throw this in at the end, but it was what Paul said which reminded me, and it was something I'd said previously, is that this is a continuation, I think. This is a redevelopment of the old 5-year programme for government. This is basically the next version, the next iteration of it. And in that, there was a very strong emphasis on well-being and people taking responsibility for their own health, which is equally reflected in Jonathan Michael's report. However, what we haven't seen lately is much visibility on the public health side to develop those themes. And I think actually we need perhaps to, in our feedback, to push that a little bit, because without that, as you quite rightly say, Paul, I think I wouldn't say we're on hiding to nothing, but the focus is on ill health and, less than ideal health, rather than getting people to focus on their own health. And I think we need to do that more, particularly as we're building the wellbeing hubs and so on, after the Western pilot and now down into the south. I think it's critical.
I think you're really strongly echoing what Paul said there.
I think so, yeah. Just I'm trying to emphasise that more in our feedback, I think, in terms of public health need to be more visible in this.
Okay, we're slightly ahead of ourselves, so I'm going to suggest we take one more item before we have our refreshment break. So, Oliver, over to you for the Integrated Performance Report.
Thanks very much. I was going to take the report largely as read, as the care groups have provided a really comprehensive narrative within each section, which is great. I think the report, Teresa in her report talked about a lot of our current operational pressures, and I think this report just highlights how we've been, our various, the performance of a lot of our services has been relatively stable since July, considering that we have been in a pretty much a continual state of COVID escalation, which has had an impact on our elective services, and also we've had our issues particularly around anaesthetic staffing having a significant shortfall of anaesthetists. So I'm not going to go through the report in detail really, but there is just one element of the health section of the report that I just wanted to highlight, because I know it's comes up at a number of sessions that we have, and that's around patients waiting for an NHS dentist. We've seen quite a significant reduction between August 21 and September 21 of 600 patients fewer waiting to be allocated to an NHS dentist. I've just got a report, an update this morning from the lead within that team that has told me that there's a further 400 off that list, so there's 1,800 patients waiting for an NHS dentist at the moment, which is a real achievement, and that's largely been achieved through the changes in the contract that have been negotiated by the primary care team. I've also got an update quickly from Sally, who sent it over earlier, because obviously she's poorly today. She just wishes to apologise for a lack of narrative within the children's and families section, and that's going to be resolved before the next meeting. She's asked me just to highlight also around adult safeguarding and the fact that they're making quite significant inroads within the adult safeguarding area, and that is leading to the development of a multi-agency safeguarding hub, which is a kind of merged team, or not merged team, but much closer working relationships team between the adult social care and the police, which is underway at the moment. And also she's also asked me to mention, as Andy just mentioned before, about wellbeing hubs. As we've now got the Southern Wellbeing Hub fully up and running now, and the consultation around the Northern Wellbeing Hub happening at the moment is actually a session this afternoon in Derby Health Centre, consultation session for the public, with a view for the Northern Wellbeing Hub to open early in next year. But that will, once the wellbeing partnerships are up and running, they'll take on the responsibility of managing all of the social work referrals, which currently go through a central team based within Murray House, but they'll actually be managed on a locality basis, which will mean that actually those social work referrals coming in will have much more of a holistic assessment, not just social work based, as per the membership of the wellbeing partnerships, which will be a great development. And then the only thing that I wanted to mention is that this is probably the last time that this format of the integrated performance report will come to the public board, because Richard's team within business intelligence have been working behind the scenes to produce a new format, integrated performance report, which cuts it down significantly from the 30 pages that we've got presented to us today, to be a much more succinct report, highlighting each data point that we're required, or each metric that we're required to report on through the Manx Care mandate, whether we are compliant with that particular metric, an indication about the trend over the last 12 months, which is something that I know that we've always struggled with in this report, because it doesn't provide a lot of historic data, and a much more succinct explanation of from within each care group as to how we're going to, if a particular metric is not compliant, how the care group is going to achieve compliance within the next, within a set period of time. So it'll be much more focused in terms of really drilling down to each individual data point, rather than being a bit more kind of on a narrative basis. So I know that we're working closely together to get that report in a format that we can present it, and a plan that the next board meeting, which will be the private board, we have the first kind of outing of that report, with it really honed down for the next public board, look to be in January. So that's all I wanted to say.
Okay, I was going to say how pleased I am how this is developing, and now you're saying we're going to take it away and do something else. But it has been developing a lot in recent months.
Mm-hmm.
You know, it's both more recent, it's got clearer metrics. I think, you know, the use of RAG rating throughout is very good. So whilst I always like to see continuing improvement, I wouldn't want to lose some of the richness of the data that we've got here. And then very specifically, because you've got so many metrics in here, there would be some which would be very much more concerning than others. And for example, last week there was a report by the Royal College of Emergency Medicine drawing attention to people waiting more than 12 hours in A&E. And the headline was that many thousands of patients have waited more than 12 hours in A&E, and of those, some will have died as a result of excessive waiting. Now, you do actually capture the 12-hour waits here on page 9, and you've got that there were 42 patients waiting more than 12 hours, which is therefore a cause for concern for us. So really what I'd like to ask is, A, what are we doing about that? But B, for this future report, will we still have that type of metric will still be included? Yeah.
Yeah, okay. Definitely we'll have 12-hour breaches in the new report, because that's clearly one of the key A&E or ED target that is you know, across the UK, and we'd seek to replicate that. In terms of reducing 12-hour waits, as Teresa said, we are pushing forward with the implementation of a same-day emergency care system. So we tend to see 12-hour waits within ED when there's a lack of capacity for them to move into. So the various different initiatives that we've got on the go at the moment as part of our preparation for winter, but hopefully the pending substantive funding, those initiatives will carry on. One of them being ambulatory care, which seeks to manage patients within an ambulatory or an outpatient environment for those who would have otherwise been admitted. So for those patients who, rather than needing admitting to a hospital bed, just requires maybe 6 hours of maybe antibiotic intravenous therapy, or a period of observation, or really rather than being admitted a daily attendance at the clinic for treatment. So we've actually seen, since it's been in operation, which is about 6 weeks now, we've seen quite a considerable reduction in the number of admissions for the time that the ambulatory clinic is open, and the care group responsible, the medicine and urgent care group, are bringing a business case, I think it's to tomorrow's business case review group, to try and extend the length of operation of the ambulatory care clinic from 9 to 5 Monday to Friday to 12 hours a day, 7 days a week. so that we can get that benefit in terms of reductions in admissions for a longer period. We've also approved at last week's business case review group, and it's to be presented to our executive management committee on Friday, the establishment of a short-term pilot to launch intermediate care. So this is an expansion of the social care reablement service, accompanied by the appointment of a small number of advanced clinical practitioners who can take referrals off the likes of the ambulance service, GPs, social workers and other community practitioners, where at the moment it would otherwise elicit an admission or a 999 call if a practitioner is sufficiently concerned about to actually require further treatment. The intermediate care service seeks to actually have, rather than bring the patient to the treatment, actually bring the treatment in the form of an advanced clinical practitioner to the patient to initiate treatment and assessment, and where required, the reablement service will be able to kick in and actually provide short-term care for that patient to actually help to reduce the chance of admission. In addition to that, in a couple of weeks' time, we've actually got 2 what we're calling step-up beds opening in Southlands, which is our care home in the south, operated by Manx Care, and that is to work in conjunction with the reablement service, where they find that somebody is not quite coping at home and requires a slightly increased level of care, but not hospital care. We've got 2 beds opening in Southlands for that function, and we're also in the process of developing that same capacity or that same pathway into Ramsey Cottage Hospital. So we're basically doing all of this to try to, to reduce the numbers of non-elective admissions during particularly the winter period. But if we are successful in our substantive funding around those various initiatives, that they'll be in operation 52 weeks a year.
Okay, thanks, Oliver. Well, there obviously is a lot going on, but I do think that you've got some sort of super red thumbs here, where you know that there's really high patient risk. You know, this would be one, long waits for an ambulance would be another, and it's almost as if you've got a RAG rating, but you need something higher than red for the ones that are the highest risk. Andy, did you want to come in?
I do. A couple of questions which actually arise from a couple of things I've already said, which is...
So intermediate care basically can relieve the ambulance service to a degree, but I picked up in the report this time we're really struggling at the moment with very high sickness rates in ambulance, which means that it's very difficult to maintain the service. Have we got anything in place other than obviously our other activities which might help us with that, or is that something we're just having to live with just at the moment?
Well, the ambulance, yeah, you're right. We are seeing incredibly high levels of sickness within the ambulance service. It's being managed on a day-to-day basis by the duty paramedic officer that is over the service at any one time, and we have seen situations where we've dropped down from our minimum staffing, which is 4 ambulances during the day and 3 ambulances at night, down to around 2 ambulances, supported by a paramedic in a response car. Obviously, that does have an impact on our response times, particularly if A&E is busy and there might be a handover delay. But unlike the UK, that is reporting some horrific handover delays, we tend to hand over within about half an hour at maximum, but it generally is immediate. We have got a, similar to the nursing recruitment drive that Paul talked about, we've got a similar recruitment drive within the emergency care assistants, which is the practitioner that sits that it works alongside the paramedic. So they're not a qualified healthcare practitioner, but they are obviously trained to assist the paramedic, and and the open day that we had recently saw over 40 people in attendance.
Oh, that's good.
And we've also got a paramedic advert out at the moment, which is seeing very, very high levels of interest.
Excellent.
And as Teresa said, we've got a new head of ambulance service, Will Bellamy, who's joining us from South Coast Ambulance Service.
Listen, Kent.
Yeah.
Okay.
Who has got a huge amount of experience as a group manager there, so managing an area in terms of population much bigger than the Isle of Man, but probably similar geographical area. And you know, he starts on the 6th of January, but he brings a huge amount of skills both as a manager and an advanced paramedic as well. So we'll be able to really drive the service forward in terms of both driving the profession of paramedic forward to some, you know, the model that we have to delivering more proactive care, and very similar to what I discussed in terms of what the intermediate care project is going to be doing in terms of the advanced clinical practitioners. It's actually being able to deliver more diagnostics and treatment within somebody's home.
Right, okay. And sorry, Teresa, did you want to add something?
I sort of just wanted to just provide some, I guess, more assurance to the board. We've absolutely recognised the pressures that the ambulance service has been under for a number of months. It was one of our priority areas for, I guess, additional support. So feeling very much part of the care group structure was the first part of that, and giving it some very clear leadership by moving it fully into one of the care groups. It was a priority for the workforce and culture team to work with, and they've done work with the team. Part of the response is around that new leadership arrangement. All of the arrangements around the alternatives to conveyance to hospital and establishing some of those interventions out in the community. So we do recognise that this has been a service which has been under significant pressure, and does have a significant amount of transformation to fulfil. Hence all of the actions we're taking. It's been a key part of the performance and accountability reviews and deep dives, and we've got a paper which is coming to Executive Management Committee on Friday, which sort of is a position statement around where the ambulance service is currently and the further actions which are planned for the future to put some stability into that service, to progress the workforce model. And it is encouraging that there was such a strong response on the island to the advert for the emergency technicians training programme. But I think it is one of our services which we recognise has required a lot of executive support over the last 6 months, and will continue to have that support.
That's very reassuring. Which leads me neatly on to my second question, which is at the other end of the scale. So, I know.
Before you do that, Andy, because Sri wanted to come in.
I'm so sorry, Sri.
On the previous point, they'll come.
I do apologise.
Sorry, go on, Sri.
Yeah, you know, I don't want to labour the point, but I just still want to make something. And I think Manx Care prides in itself in what we want to be data-driven, evidence-based and clinically led organizations. When we talk about data-driven, I think lots and lots of data keep coming in all the time. We know about the fact that 4-hour target is being abolished at the NHS UK. We also know that the patients who are admitted over the weekend tend to stay longer here. We don't have a 7-day service. We also actually know that patients who stayed longer in the first episode of their stay will likely to come back. Readmission rates again are higher. So there is lots of data that is coming in. I think the key for Manx Care would be to bring that data which is useful for us, rather than actually unfiltered data which we are not going to be using it for any benefit as such. I think that would be the key one, and we got that liberty to do that. And I think you will see that in our future board meetings, which Paul's kind of trying to allude to, that 10 point. So we will bring the data out which is actually relevant to our kind of system, and how we're going to deal with that, which includes what Teresa's just said about the ambulance. We do not currently triage the ambulance calls. which will actually would have alleviated the workforce pressures in ambulance because it sits somewhere else. Actually, it doesn't sit within the care groups. So those are all the things that we will bring it down to actually operational level, so that actually it makes meaningful data, so that everybody can actually understand what's the point of that data. It's there. Currently, at the moment, it sits in, but we got that now liberty to do that. Sorry, thank you.
It's a good point, Sri.
Yeah.
And is it the same point, Richard?
It's to build on it, really. I think this is a hugely exciting time for Manx care. Just building on what Katie and Oliver have said, and to address the point that Shree's made, the previous integrated performance reports that we've seen since the establishment of Manx care have all been manually created. They've all been pulled out of spreadsheets and workbooks, etc., and manually cranked. What we're starting to see now, and we'll see next time, are automated reports, the reports that are coming directly out of the systems. And that suddenly changes the game. That allows us to do an awful lot more with that data and to be able to access the kind of information and knowledge that Shree's talking about. Oliver mentioned the fact that he and I work very closely together to try and get these reports right, and then to start to look at what does that data tell us, what meaning can we glean from it. And the whole discipline of performance management is something that's been very difficult when this is all manually created. Certainly that opens up a new range of things that we can do. I know that, for instance, we've been talking, Paul and I have been talking about dashboards for wards. So suddenly being able to access this information enables us to create new dashboards, which maybe Paul would like to talk to. That'll make us, enable us to have a completely different view of what's actually happening on the coalface.
I think what that will help us achieve is what I refer to as managerially labelled and clinically led. Mm-hmm. That's what Sri and I are really committed to, is to get the strongest possible clinical leadership, and that will be massively enhanced by really good quality insight and foresight from the data that we're getting. And I think we're not far away from that, Richard, as you say.
So it's been a fantastic catalyst, this drive to get this quality data up, and it really is a great opportunity.
It's definitely moving in the right direction, absolutely. Andy, do you want to make your different point? And then we'll
I do, and actually, just as an aside, in my amateurish way, what I'm trying to do is make the connections between things. So Ollie mentions intermediate care now, that will relieve the ambulance service to a degree, which you should see in the data. And then my last point was about integrated primary care services, which community services, which I know I've mentioned before, failing their targets regularly, so they're not seeing the people that they need to. Because of the wellbeing hubs, I would expect to see that improve fairly rapidly as they take effect, and as intermediate care begins to take effect, because when they see those, they clear them out the way. And it mentions the fact they're under pressure, particularly because of low levels of activity in orthopaedics. What I really need to see coming through in the data for assurance is you need to see the dynamics of some of those changing as those interactions occur, and in the narrative pointing out how one is impacting on the other. At the moment, these things aren't connected. They're individual chunks of data without that web of interactivity. And as the integrated care partnership board begins to develop its pieces, particularly in intermediate care, and I think the falls probably is next. Is it, Oliver? Is the falls part next? Those should begin to impact on some of these, and we should see them in the data, and we should be able to see the connection. And with a bit of luck, Rich might be able to pick them out for us in a web. So constellations of the data rather than individual chunks. That's it. Sorry. Thank you very much.
So in summary, we've got a report that has been improving month on month, has been getting more automated month on month, and is going to continue to be manipulated to provide the most relevant metrics that we want, and ultimately can be expanded to a sort of ward level dashboard as well. So I think that's all very encouraging. Right, should we take that break now? Sorry it's a bit late, but we've got a bit further in the agenda. So if we can restart at 1:45, please. 10 minutes, thank you. It's 1:45, so let's restart. So we're up to the item on restoration and recovery update. So Oliver, over to you.
Thank you. So just as a bit of background, so I think the last meeting the last public board, we talked about the provision of the successful business case that we've put through for 1.86 million to fund a series of initiatives to help us recover the waiting list backlog that has accrued during the period of the pandemic. And that was going to be focused on a number of outpatient specialties to be delivered by a virtual outpatient provider called Medifer, and a lot of a chunk of activity to be commissioned externally by in the areas of endoscopy and also cataract surgery. So I'll take each individual kind of project. To start with the Medifer project, this has proven quite a challenging project to reach its conclusion, mainly around the data sharing side of things, because we really need to make sure that our data sharing arrangements are really kind of copper bottomed. I'm glad to say that those arrangements have now been signed off, and we're looking to start with the Medifer consultations, particularly within four specialties, which are cardiology, pain management, dermatology and respiratory, and they're due to commence in the beginning of December, so a couple of weeks' time. So patients who are waiting within those waiting lists will be contacted by a Medifer consultant in the next few weeks. In terms of the other areas, so we originally had signed a contract with a company called 18 Week Support to deliver our cataract and endoscopy activity. Now, due to the significant workload or demand around restoration that's coming from the UK, unfortunately the 18 Week Support are no longer able to support us within those areas. So we've had to make alternative arrangements. So within the endoscopy side of things, we're actually going to be delivering all of that additional activity internally with our own endoscopy staff and surgeons and gastroenterologists. And we're going to be able to achieve that within the same timescale as we'd originally anticipated, but for actually less money than we'd originally projected, which is good. So we've actually started that work already. So we've had a number of pre-assessment clinics that have taken place, and the first additional endoscopy actually took place. Well, there's actually two weekend sessions that have taken place earlier on this month in November, and then last weekend. So we are moving ahead with that. From a cataract point of view, we're looking at alternative arrangements at the moment. We're slightly hampered by the fact that, unfortunately, the equipment that we currently have within theatres to undertake cataracts, a lot of the insourcing providers, so those companies that are going to come to the island to work, actually are not able to use that equipment because it's not they're not trained to use it. And we have looked to hire some equipment, but unfortunately it's not available because of such high pressure across the NHS to recover the cataract position. There just simply isn't any equipment for us to hire. So what we're currently looking at is actually some off-island alternatives for people to go across to have their cataract done as a day case procedure. So the idea is that they fly off to the UK, have the procedure and fly back on the same day, if that's possible. And that's just something that we're looking at the moment. So it's possible that we may not be able to achieve the entire cohort of recovery for cataracts in this financial year, but we're going to be having discussions with our DHSC colleagues and Treasury just to see whether we're able to carry some of that funding over to the next financial year, so that we can continue to use that funding that we've been allocated. In terms of the positive, on a positive note though, the reduction in funding or outlay that we have that we're looking at in terms of endoscopy has actually enabled us to be able to invest that surplus into another initiative, and that is actually within mental health. So we're actually in fairly well the final discussions within with a on Ireland third sector mental health provider to actually provide some additional capacity, particularly within the paediatric or children's, the CAMS service, and those younger adults, particularly around cognitive behavioural therapy, which we know that there's quite a significant backlog within that waiting list. And so we, as I say, we're in the very final discussions in terms of contracts and data sharing agreements with regards to that, and then we hope to have that starting in December, which is going to be a significant improvement in the waiting list position, particularly within the children and adolescent mental health services and the young adult services within the mental health service. The only other thing to mention in terms of restoration and recovery, what we don't want to do is to be in a situation where we are given this pull back our waiting list position, and because of lack of improvements within our administrative areas, that we just slide back to a similar waiting list position than where we are at the moment. So we want to make some substantive changes to the way that we manage our waiting list, both within the inpatient and the outpatient side. So the first draft of the access policy for Manx Care came to the Executive Management Committee about 3 or 4 weeks ago, which was approved with some changes to make, and that's coming back to the Executive Management Committee on Friday for final sign-off. So that is basically our Bible in terms of how we will manage inpatient and outpatient referrals, to stop them, basically to stop referrals either being lost in the system, or to make sure that referrals that are either so that patients that do not attend their appointment are within a certain number of they're given a certain number of repeat appointments, and if they fail to attend a number of times, then they'll be removed from the waiting list, etc. So it's really our kind of administrative Bible to stop us sliding back into a similar waiting list position than where we are at the moment. So we're doing various different initiatives as part of the recovery and restoration project to both get us out of the to recover the waiting list situation at the moment, but also implement substantive changes to help us maintain that improved waiting list position.
Thanks, Oliver. So you described a whole load of actions that are in hand to target the existing waiting list problems and to improve the system. Having done all that, where is the area of greatest concern? Where are the longest waits which are most clinically concerning?
I would say at the moment probably the area of most concern is endoscopy. They're the areas where we have the most the highest waits. But as I say, the programme that we have ongoing at the moment will clear the endoscopy backlog completely. In terms of other areas, the areas of greatest concern from an outpatient point of view are particularly within cardiology, which again is part of is within the programme of work that Medifu will be focusing on. And then in terms of from a surgical point of view, the specialty that's been hit hardest particularly during the pandemic, and most recently during the kind of combination of pandemic and our shortage of anaesthetists is orthopaedics. although orthopaedics you could classify it as a cold specialty and elective specialty, clearly we have a large number of people that are waiting on average about 18 months between being added to the waiting list and being operated on at the moment. And because we're effectively we're not carrying out any elective orthopaedic surgery at the moment that requires an inpatient stay, an overnight stay, that waiting list is just increasing. But as part of the work that we're doing as part of the recovery and restoration piece, we are also in dialogue with some private hospitals at the moment to be able to secure an agreement to offer some choice to patients who are waiting for an elective orthopaedic procedure, to actually give them the opportunity to have that procedure in the UK. Clearly that is going to be a financial implication to us, so we're just in the process of finalising a business case to go through to our colleagues in DHSC to approve that. But you know, clearly that is a priority that we want to particularly clear the orthopaedic, because based on the current situation we are around COVID escalation, it's possible that we won't be restarting our elective orthopaedic programme this financial year. So we do want to be able to offer an alternative to those patients who have been listed for an orthopaedic procedure, so that they can receive their procedure, particularly those who are at the top of the waiting list, receive their procedure earlier than the April.
Okay, thanks, Oliver. Sri?
There are a couple of clarifications that I wanted to make on this one. When you talk about the areas of concern, I'm sure you meant that where are the patients at risk?
Yes.
You're meaning that, not the numbers as
Not
such.
numbers, no.
Right.
Risk.
I think it's quite important to see that this access policy is underpinned by clinical harm review process that actually looks at every patient who's waited for longer than what is required. It goes through technical clinical validation process that will tell us whether the patient has suffered any harm, not because of treatment, but just because of simple waiting on the list for greater than 52 day or 52 week or 2 weeks, or if they breach that standards that are being set nationally or internationally rather. So the point is, that's the first bit. The second bit is about the fact that whether all this extra help that we are going to get, whether through Medifer or through extra endoscopy or through orthopedic procedures, it is up to us, our clinical directors, our clinical structure here, to actually pick up those clinical risks and triage the patients and send the patients to these appropriate places. So the access policy is as good as anywhere else at the moment. I think this will actually pin the governance that is needed for making sure that, and assure the board that the patients are not put at any risk or there's no harm that has come about. Just one specific point, the number of referrals to certain specialties over year on year have significantly gone up. One is endoscopy, number 2 is dermatology. You know that the reason for that is because people are a bit averse to kind of doing anything about symptoms. So Royal College identifies 5% increase on year-to-year increase in number of referrals for endoscopy. Dermatology is about similar number.
So these are people that would have come during COVID but didn't?
Not just that. The people are not being treated elsewhere by any other thing. They would actually put through the common pathways to make sure that is, just to give you an example, so in the 2-week pathway for dermatology, I think I've looked at, I think the numbers are up, I can't definitely tell you, it is about less than 1% of people who are put through 2-week pathways in dermatology are actually cancers. So that itself tells you that there is lots of other pathways that can be dealt with, which is what we are addressing at the moment, training the GPs, making sure that they can identify and treat them properly. Obviously, it's not possible in every single clinical pathway, but those are the underpinning things.
Okay.
Thank you.
Teresa?
Yeah, I sort of just wanted to acknowledge the level of work that has gone in here, and I know the board could be asking, well, we were given the funding in May and we're still talking about mobilising this piece of work in November, and I think it's a level of frustration in us all that we haven't been able to respond quicker. But I think this does highlight the level of work that is required to set up new contracts, new information sharing agreements, new governance with partner organisations who are going to be delivering activity on our behalf. And we have had somebody very senior, full-time, dedicated on this piece of work in Alan Wilson. So I think, and even things like identifying that the equipment we have on island for ophthalmology does not and is not compliant with what would be used in standard UK hospitals is a significant learning point for us as we develop our strategic partnerships and we look to deliver our strategic objective around sustainable clinical services. So I probably just want to acknowledge the point that there's a significant, huge amount of work gone in to even get these agreements up and running. But ultimately, it very much signals that we need long-term strategic partnerships because we can't be doing this level of work for every time we want to respond to a waiting list challenge. So it requires an underpinning strategic partnership strategy whereby we have the governance arrangements, information sharing agreements ready to go so we can respond and ultimately deliver the ambitions of the island plan in reducing our waiting times.
Good point. Nigel.
I'd like to just ask Teresa, because I think it's a really important point. You know, one of our aspirations as Manx Care is to be the best small integrated health service provider in the world. And I'm getting this, a lot of talk about strategic partnerships. We are where we are, and clearly it's a difficult situation. We're playing catch up. My question is really further away. So are we learning a lot about how we structure strategic partnerships and strategic alliances so that in the future we don't necessarily have to simply abide by what is the international standard for waiting lists? Why should we have waiting lists? Well, if we're a well-funded, integrated health service care provider, why can't we see somebody the next day? It doesn't have to be 2 weeks. Could it be a week? Or it doesn't have to be 4 weeks. Could it be 2 weeks? Could it be really quick, really snappy, and really joined up, is what I'm saying. And are we learning those governance arrangements from this period of stress and crisis to be able to put in the building blocks to enable us to get to the sunlit uplands in the future?
Yes, I think we are. We've obviously through the summer and the change of transformation partner with Cabinet Office had the opportunity to reframe some of those pieces of work responding to the 26 recommendations of Sir Jonathan's report. And I think one of the fundamental areas that is really, really important is what sort of strategic partnerships do we need in the future and who with? And what are the opportunities beyond what could be just a clinical delivery partner? It goes much further than that. How can we work with strategic partners around an aligned governance framework, an aligned IT and digital system? We don't need to reinvent the wheel. We can take the best bits of the wheel and implement them here, and we can set our own standards. We have the ability as Manx Care to move money around the system. So that freedom to be able to redesign how our hospital services are profiled and how we design our community provision and our out of hospital is within our gift. And I would suggest we're building the fundamentals of that by absolutely investing in the hubs and those locality-based models. But, I think we have got a big journey. But what has become incredibly apparent is when you talk at sort of acute hospital-based services and at specialty level, we do need some very strong strategic partnerships in order to respond to the clinical and financial sustainability, clinical and strategic objective that underpins Manx Care. And I think we've had an awful lot of learning in the last 6 months, and we'll continue to evolve that journey. But I think that priority around who are our strategic partners is incredibly important, and we're starting to understand more of that and what that could look like and what type of partner we want through that piece of transformation work about what we do on island, what we're very, very good at and what we build and what we expand on, what ultimately we perhaps can't deliver on island, and then all of those services which sit in that probably that middle ground where we need to take a judgment call and perhaps build sustainability in those specialties and those particular services.
Thank you. Really encouraging. Right, let's move on to finance then. So, Jackie, over to you.
So I'm going to take the management accounts as read, but just a couple of salient points that I just want to highlight for you is some of the things that are driving our forecasted projected overspend. Most of them will be, well, pretty much all of them will be familiar to us by now. One of the things we've been doing since the management accounts have been produced, and it was mentioned in the report there, was identifying and extrapolating additional COVID costs that are sitting within our baseline that haven't previously been identified. So an enormous piece of work has gone into doing that over the last few weeks, and we've identified approximately 8 million of COVID costs that are currently in either our baseline or our forecast, and are working towards a business case submission with our partners in DHSC for that. In addition to that, obviously there are other pressures that we face. We have the continued closure of the private patients unit. So we began the year with an income target for private patients unit, but the unit hadn't been open for quite some time, and that's still not open for varying reasons to do with governance, COVID, and other operational issues. So that's creating a big pressure. We've mentioned previously about tertiary activity. So obviously there's been a big uplift in the forecast for tertiary activity. A lot of what's driving that is this elective activity that's happening in the UK as part of the UK's restoration and recovery, and our patients are being swept up in that because they're not treated any differently to regular UK patients. In addition to that, we're looking at potential winter funding pressures. There's been a recent uplift in the tariff, which was agreed. Again, it's agreed across the system in the UK, so that's created a further pressure. But we've also had some offsets in there around, the renegotiation of the off-island patient transfer contract has realised some savings, and we've renegotiated a couple of other block booking contracts, which again have delivered savings in the year to try and offset that. But obviously, tertiary activity remains a very volatile area, and a lot of it is entirely dependent on the pressures in the UK system and what's happening there. So, it could either, if the UK accelerates its activity, then it has a cost pressure for us. But similarly, if activity reduces in the UK due to winter pressures and so on, then it can reduce. So that remains a volatile area for us. Employee costs is another area. We're experiencing significant overspend in certain areas, primarily being driven by agency and bank costs to cover vacancies. So it's really encouraging to see the progress that's being made in terms of recruitment across the piece, because it's only by having substantive staff in there that you stop paying that premium for having locum, agency and bank, and that's the only way really we can start to bring ourselves back into a sustainable way. So it has financial implications, but obviously it has safety, governance, quality, to have that continuity of staff in there rather than just locums coming in and out. Another pressure that the system is experiencing, which is largely outside of Manx Care's control, is around drugs costs. Excuse me. So there's evidence that in the wider drugs marketplace that costs are going up significantly. Certain shortages and stockpiling behaviours as a result of supply chain issues around COVID and around Brexit have driven certain behaviours which have exacerbated the problem. We've also got pressures arising from previous decisions around cancer drugs and cystic fibrosis drugs, which are now coming through the system, which are driving up our usage. And I think the point that was mentioned earlier about nice TAs, we do feel that even though it's unquantified, there is a significant element of that actually coming in through the back door, as we said, driving up those costs. So mitigating that, which is connected to our SIP programme, there's there's really big pieces of work going on around medicines optimization, establishing an Isle of Man formulary, doing lots of activities in there to try and mitigate that. But realistically, all they will do is mitigate a pressure that is really very much outside of our control. And I think the other area to talk about is our SIP. So obviously we've got our 2.7 million target. We've actually set ourselves a stretch target of 3.2 million in order to give ourselves a little bit of leeway or the opportunity to overperform. So far, delivery we're reasonably happy with delivery. There are some risks in there around resource, around capacity. We've talked about our staff and how they're having to deal with other operational pressures. So the work that MIAA have been doing to support us has been really helped to accelerate that delivery, and we're starting to see we've generated 1.3 million of savings so far this year, which I think is really encouraging. There remain, say, some risks around in terms of the medicines optimization is some of the items of self-care, because that relies on some input from DHSE and some policy support around that. And we've identified a couple of additional SIPs again around medicines optimization, reducing wastage, particularly in our secondary care pharmacy. So it's all very encouraging, and I think the next step for us now is to try and now look at what our future SIPs might be to deliver into next year. I think what we're finding is a lot of the work that we're doing is generating savings in this year, but actually the big savings are next year when we feel the full 12-month impact of those changes, where in this year we might have 4 months or 3 months or 1 month or whatever. So it's really, really encouraging. So I think I shall leave it there for now and open the floor to any questions or comments.
Well, I know that this has already been very heavily scrutinised in the Finance Committee, so I don't know if anybody's got any additional questions they want to ask. I think this has been, that's a very good account of pressures outside our control, pressures inside our control, actions that we're taking. So I think, Jackie, people do seem to have covered this before. So do you want to move on to the capital report?
That's Barbara.
Barbara, sorry.
Hopefully everybody's read the report. This is a summary of our major schemes of all the capital. The biggest scheme currently is Summerhill, which is progressing well. However, is looking to be maybe around 9 weeks behind schedule due to COVID and such like. There's opportunities for that to be reduced over the forthcoming months. I'm happy to take any questions if there's any questions on any of the projects.
It was good to see that report, Barbara, because it just underlines how much is going on. I mean, there is a huge amount going on, isn't there, really?
Mm.
And many of these projects will have been started quite a long time ago.
Yes,
But,
yeah.
Now, so any questions for Barbara? Yeah, Andy.
Just have one. Barbara, on Summerhill,
Yeah.
I know the one thing I did notice was that it said the proposed budget was 6, but it had been driven down to 4.5. Is that, are we compromising on what we're getting? Or is that...
No.
So it's
No,
just,
so there's...
is it just literally shifting money around between years?
Yeah, it moves between the years. So throughout each year on a quarterly basis, we redefine the expenditure, the planned expenditure.
Right.
So I constantly look at the planned expenditure against what we've spent and to reevaluate that with Treasury, so that Treasury can alter what they've got in the capital pot, if you like.
So we're still going to be getting that state-of-the-art
Yes,
home that we
yes.
always intended?
So the final budget is exactly the same. It's just the
It's just the
fluctuations,
movement
if you like, within
Right.
that, because it's obviously several years of expenditure that it comes in different forms depending on what we're purchasing at the time and where you are in the build. So it's constant.
I was just concerned. I didn't want to see any compromise on
No, definitely
delivering something
not.
which
Oh,
was going
no.
to be, top notch.
Yeah, it is. Yeah,
Brilliant.
beautiful building. Yeah.
Thank you very much.
Yeah.
Any more questions for Barbara? Yes, Jackie.
Just a point of clarification. I know most of us around the table will be aware of this, but the way capital is financed and is organised and is controlled sits slightly to the side of Manx Care because the assets are still controlled by DHSC.
Yes.
Is that right?
Yes. Yeah, controlled by DHSC with Treasury, so the money sits within Treasury and is drawn down as expenditure is applied to each scheme. So it's not a pot of money that we have, and it's agreed up front by Tynwald. It isn't something that we can vary. We cannot overspend. It has to be spent to the letter. Most projects, I'm trying to say this in case it all goes horribly wrong, but most come in as an underspend, and that is my aim, is to underspend on a project because we can then give that money back to Treasury.
Thanks, Barb. And can I just come in? It was just one further point, and I know, Barb, you and I have spoken about this before. It's that capital projects by their nature are set in train many years ahead, and obviously now with the inception of Manx Care, there may be there's a slightly different strategic direction, and I note that there's a number of these are enhancements to existing residential facilities, and I just wonder if a review or some conversations are happening where if our emphasis as a system is to move people out of residential settings and into their homes, should we be investing or continuing to invest as much as we are in our residential settings? The answer may well be yes, because the demand level is there, but I'm just curious as to what conversations are happening to make sure that we're on top of that.
Yeah, so I discuss the provision, especially with the new Director of Social Care, so that we make sure we've got the provision in the right place. So I would say for the estimations that have been completed so far, these are new facilities that don't necessarily increase the beds. They're the same beds. It's a new provision. There isn't any. There aren't any schemes at the moment that actually increase those beds. So it's about new provision. I think what we must do for the future, though, is make sure that we have the ability to readjust that building for the future, so that we internally we're not looking at just bricks and mortar. We're looking at a flexible build that can then match the alteration of standards or the use of a building for the future, rather than this constant we will rebuild all the time, because we as an island have not got the money to keep doing that, and we need to look at creatively how we can work for the future to do that.
Thanks.
Okay.
Teresa next. Oh, plenty of people. Teresa next.
Sorry.
Thank you, Bob. I wanted just to talk about the asset replacement scheme and
Yeah.
whether you feel we've got enough control, grip and oversight about engaging with the operational teams about building that asset replacement programme. And then secondary, whether we've sort of got a process for building in the revenue consequences of such new equipment, because sometimes, you know, the new bit of kit is all well and good, but the revenue consequences associated with installing it and running it is something which isn't always factored in as strongly. So it's whether we can do any more to help you, and whether Manx Care has got the good oversight on this to make sure we've got, you know, a rolling equipment replacement programme.
I think we can always do better. We don't have, as you know, there aren't many resources within my team to actually manage this, and so I think the help is trying to ensure that the clinical teams understand that they have a responsibility to manage their assets, which has always been the case, but I think it's always left as sometimes it's a last minute, and then wondering why, you know, have you not got the money to do this? We obviously have the asset programme, which has an estimated value, and which is what we then apply to Treasury annually to increase that budget. I think going back in time, moving into Nobles, we had a massive investment in new equipment. However, that's now coming to the end of its life, and I think that's why we're seeing a drive to replace kit, and also kit like the ophthalmology kit that is probably not now the best to deliver that service. However, it still works. It's still providing a good service here. It's probably not been used to the extent UK kit has, because it hasn't been battered to its absolute the end of its life, if you know what I mean. So we've still got to manage the assets in the what life have they got against what do we need technically to manage that clinical service, and it's a big balance, and it's, like I say, is reviewing that annually to look at what budget we have, what budget we can bid for, and also the charities who are amazing in supporting us with that new kit as well.
Yeah.
Well, I've got three more for you, Barbara. First of all,
Yeah.
three.
Couple of quick questions.
Yeah.
Probably very naive on my part. You know what? Some time ago in NHS, to raise the capital bids, lots of NHS trusts, organisations, whatever you want, they disposed of their surplus lands to get that. That's the first question. What happens to the assets that we own, and what happens to those money that will come out? The second bit is, I was also thinking about the loans. Can we, as a Manx Care, can we actually independently go loan from somewhere else that will actually, and then build our own kind of finance stream with them? So that's, I know it's a bit of a very naive question, but I was
It's all right. No. Any more of those? Is that just the two questions, is there? Yeah, go on.
Yeah.
Okay.
I don't want to ask third no.
Firstly,
I don't want to risk it.
Firstly, the land. All land is owned by Isle of Man government, so if we were to sell a property or a piece of land, it automatically reverts back into the land bank, or to the monies go back into Treasury. So it isn't money that we would have at our disposal. So that's the first one. And loans, no, can't do that. I mean, Jackie's probably more au fait with the financial regulations and such like, but it's not something that we can do.
We don't resemble NHS trusts.
No.
I thought
absolutely.
No,
There would be a
it's worth
perfectly reasonable
asking.
question in the UK,
Yeah.
but here the rules are different.
Yeah.
So
Yeah.
I'm afraid not.
Sorry,
so, no,
sorry,
you
Sri.
Yeah, the island gets quite excited about Treasury boards of Tynwald forming subsidiary companies to borrow money, as you can understand. So it's really about space. In the early days of this board, Barbara, we were implored at the Let Us Listen sessions, and also a very good presentation that we were given by A&E to provide us with space that is fit for purpose, and reverse where, in some people's views, silly decisions had been made about the use of space. We talked about that, and we've addressed it, I think, with a space audit to start off by saying, what have we got, what are we doing with it, and where is it? How is the space audit going?
Going back to it, if we start with A&E we're working with at the moment to look at redeveloping A&E to make sure that it's fit for purpose and it matches what we need. I think that's a project that's going to be in phases, because I don't think we can do it all at once. We won't have the funding to be able to do that. With regard to the audit, we have done that in some small ways, but due to the lack of time, it's not something that I've been able to give much time to. To be honest, I'm not going to tell you that I have when I haven't, because I can't do it all.
I think we need to keep
Oh yes, most definitely, yeah.
Okay, and finally, Paul.
Thank you. I just wanted to thank Barbara. I think this is one of the first times in my career I've seen such detail on capital programmes, and found it very helpful. But it also tells me what we're doing, and I'm wondering, my interest is in what's in the pipeline as well. And I'm wondering, is there a mechanism whereby we are capturing the capital expenditure needs that lie ahead, so that we're able to budget accordingly, and then more importantly prioritise, because there isn't an unlimited pot. Is there a way in which the board can gain that level of insight? Is that something you have?
Yes, the majority are here. There's also a second set, if you like, which is the minor capital expenditure, that is the smaller projects that are done in-house, which doesn't sit within this. It's a separate budget. So with regard to capital, it's those discussions take place with the clinical leads, with the leaders, to look at what's the service need for the future and how we're going to develop that. I think the key for us, for Manx Care, is we now need the strategy to drive that for the future. Yeah. They're looking at integrated care, the hubs and such like. How do we develop those? We've started small, because that's the facilities we had and the funding we've had, but how does that expand for the future, and how do we develop the services across the whole island, which is what, like I said, we need a strategy for the future.
Okay, thank you.
Yeah.
Right, okay, thank you. Well, I think that ends the agended items for the board. I've got no other business, but when it comes to questions from the public, as ever, indebted to Mr. Mann, who kindly sends us his questions in advance. The first one follows on from the discussion we've just been having. Mr. Mann asks, could Manx Care please report on the modernisation and redevelopment of Noble's A&E department? My understanding is that this was due to be funded or part funded by private donation, so I'm seeking the precise position as to whether it's still in the planning stage, gone out to tender, or whether it's still only a proposal having gone no further since earlier this year. So this is sort of Oliver and Barbara between you, really.
It's in the planning stages. We've had a few meetings. We're looking at, we've got a design from ED as to what they want to see out of it, so we're just looking at those plans and working them up at this moment in time, and we've sought advice from UK experts on ED design and what the ED needs to look like for the future.
So can you just plot out a bit of timetable ahead?
Yeah, we're just about to go out to on a what's called a mini competition for a quantity surveyor to cost up the projects that we've got, which are different phases. So there's internally into ED as it stands, and then to look into build a 6-bedded ambulatory care unit to add on to A&E.
This is another instance like the trying to commission these resources from the UK. Manx Care has now been in existence for some considerable period of time, and it hasn't really moved forward much from where we were when you first came into being. So I think we could do with having some kind of structural dateline now for when we're going to have a new accident and emergency department delivered, because at the moment it's a crucial position for people on this island when they're turning up and as we're hearing now, having 12-hour waits in accident and emergency in a small island hospital. It's absolutely reached the appalling
So Barbara, is this a fair criticism that we've not done much for the last 6 months?
I would say we've done quite a lot in the last 6 months. I don't know, Oliver's been involved as well. It takes quite a while to establish how the... I think firstly it's not a new A&E department. We won't be having a new A&E department.
No,
this is about adapting what we've got to the best of our ability to look at how we can make the services best run and to meet all the criteria we need to.
Do you want to answer, because Oliver, there have been adaptations, haven't there, to, for example, create new ambulatory care units. Do you want to?
Well, not so much adaptations physically within the building, but you know we've changed various different uses of the space that we have available. So I guess that the biggest change in the last 12 months is the allocation of what was the fracture clinic to become part of the A&E footprint, and that has created what we're calling basically the minors and ambulatory care unit. So meaning that patients that attend with a minor injury or illness are seen in a different part of the department to those with a major, significant problem, either people who come in through fire ambulance, for example. But we do have severe, severe challenges in terms of how the building was originally built back in 2003, and one of the major challenges to the particularly the nursing staff is because we're lucky enough to have a side room based A&E department rather than cubicles, which is great from an infection control point of view, but because they're all separate rooms, it means that keeping an eye on everyone that's within the A&E department can be challenging. So one of the changes that we're going to be making is actually removing the fronts, the brick fronts of each of the cubicles and changing those, replacing those with glass sliding doors, so that actually we maintain the isolation. So people that are within each cubicle are there's no risk of them being overheard, which is obviously a risk in other A&E departments where they're just cubicles with curtains separating them, but also with the glass front means that those patients within each room can be observed. The other area that we're going to be developing is an isolation area. So patients who are brought in who are either known COVID positive, or they may have been contaminated. So we had somebody attending in the last few years who had contaminated themselves with fertiliser, and we didn't have a place to put them. So those kind of areas where they're very much separated, both from a physical point of view with their own air supply and things, that's one of the areas that we're going to be developing. And as Barbara mentioned, we're going to be within the plans looking to build a 6-bedded ambulatory care area for those patients that don't need to be admitted but need maybe 12 or 24 hours of observation. At the moment, our only alternative is to admit them into AMU, but this kind of observation area under the care of the A&E staff will help to both reduce the pressure on AMU, the acute medical unit, but also mean that patients can more, if they need to stay, they don't need to be admitted, they can be discharged within a short period of time, which once you're admitted isn't always possible. So I think it's required quite a bit of consultation. We've been lucky enough to secure the input of an A&E consultant from Cambridge, Adam Brooks Hospital, who is recognised as the Royal College of Emergency Medicine recognises her as probably the best clinical expert in the country around ED design, and she's been working quite closely with Gareth Davies, Dr. Davies, who's the clinical director for ED, plus the matron for the area, and myself and Barbara. So yes, it has taken a while, but it's trying to use the money that we've got to make, to the best of our ability, really. As Barbara said, we don't have sufficient funding to completely rebuild the A&E department, and that would be logistically very challenging because we have to keep the A&E department running to full capacity whilst we are rebuilding it. So we are making what we think is the small incremental changes to the betterment of the whole department.
Well, can you take Mr. Mann's second question, which is that he says, I understand that the delay on moving patients through A&E has continued, which we've heard about earlier on today. This has been exacerbated by wards still being closed. Can Manx Care report on how many and which wards have been closed in part or throughout the period of the last 3 months and the reasons for the ward closure?
So as it currently stands, we have Ward 4 closed, and we have Ward 12 dedicated to managing COVID patients. The reason that we've closed Ward 4 is to basically improve the staffing situation. At the moment, we don't have sufficient nursing staff to keep Ward 4 open, and so what we've decided to do is to close Ward 4, which is the women's, which is the gynae ward, and to relocate those gynae inpatients to Ward 2. And there is a specialist gynae nurse that's been reallocated to Ward 2 to manage those, to look after those patients. And the day cases, gynae day cases, have been put through the day case unit. Ward 4 is still operating. The early pregnancy assessment unit is still operating, but that is a kind of clinic or short stay facility. So currently we have Ward 4 that is closed from an inpatient point of view, and we have Ward 12, which is the elective orthopaedic unit dedicated to COVID patients, and that has currently got 3 patients in it, 2 patients that have got COVID-19 and 1 who's just recently come out of their period of 14 days. In the past, so the past 3 months, we in the previous iteration of the COVID escalation plan, we had Ward 1 allocated as the COVID ward, which is normally functions as our acute medical unit. We back in July, we had that ward completely dedicated to managing COVID patients, which meant that acute medical admissions were managed on Ward 2. More recently, when our our COVID patients reduced towards early to mid-August. We reopened Ward 1 as the acute medical unit and had COVID patients managed alongside non-COVID patients within that ward. When we started to see another increase in COVID patients, which was towards the middle of October, we did have a situation where we were finding it difficult to manage COVID and non-COVID patients on AMU, and AMU is the main receiving ward for patients from ED. So we took the decision to change the escalation plan and to dedicate or allocate Ward 12 as the COVID ward, which meant that AMU could move back to its core function as admitting and assessing and managing acute medical admissions. And since we made that decision, AMU has largely been has maintained a good flow, and we haven't seen a 12-hour wait within A&E for about 2 weeks now. So the changes to the configuration of the ward has improved flow, particularly for patients requiring admission from A&E. I guess it's worth noting that whilst we have had a number of 12-hour breaches reported, we do sometimes struggle, particularly within the hospital, around particularly patients who require a side room. So if they're admitted through, or they come attend at A&E and it's identified that they need a side room for isolation, for example, if they have an infection that requires isolating, so separating from the rest of the ward. And sometimes, because we do have a limited number of side rooms, that can result in a prolonged period of wait within A&E, whilst one of those side rooms is freed up, because quite a lot of the time all of the patients within side rooms are required to be in there because of their infection. One of the changes that we've recently made, that Paul's implemented alongside the infection control team, is patients who are admitted or transferred from the UK, from hospitals in the UK and brought back to Nobles to continue their treatment, have required to be isolated for probably about a week, whilst we undertake a series of tests for a hospital-acquired infection called CPE, which stands for carbapenemase.
Nearly.
Something.
We're wandering a bit away from ward closures at the moment.
Yeah.
Oliver. We're into.
But yeah, I'm just kind of explain. But that's one of the reasons why we have why we do see kind of prolonged waits within A&E. So it's not just necessarily the fact that we've closed wards. There is other challenges, particularly around patients requiring side room isolation.
If one looks at what's actually happening, back in 2019 I petitioned Tynwald to try and get something done about the provision of emergency services. Actually everything has stood still, and we've now got to a crucial period where we've gone from what was a position where it was looked at as bad to spend 4 hours in accident and emergency, and suddenly now we've got to a position where, okay, just a few weeks ago we had people sitting in there for 12 hours. We've gone past the crucial stage, we've gone past the dire stage. If there was some, God forbid, some terrible emergency, disaster that occurred on the island at the moment, Nobles Hospital simply couldn't cope with it. And that has to be a management failure somewhere, Mr. Foster. I'm sorry, it comes down to this new organisation. No, but I bring it up because it's a major issue, and it's evaded the whole meeting today.
I think you'll find that all of us have been discussing the issues of waiting times in A&E and the adaptations to A&E to improve that. So I think we would agree with you that it is a concern. I don't think we would agree with you that it's a management scandal. It's a matter of trying to make the best of what we've got within the resources that we have, which we are definitely trying to do. Just in view of time, I'm going to need to bring this to a conclusion. You've got 2 more questions here. You've kindly agreed that one of them about GP provision in the north of the island we'll bring to the next meeting because we can't answer that immediately. And then the 4th question you asked was really one which is for public health about the particular vaccine makes and the results from them. So we can't answer that one either, I'm afraid, but that really does need to be directed to public health.
I would simply, Mr. Foster, please remind everybody around this room. Unfortunately, I don't think there's anybody in this room that can remember the Summerland disaster. Well, you'll know what happened that night, possibly. And we're heading towards a similar position. If there's ever something similar to that happens on this island, there were massive lessons learned then. And unfortunately, that the entire health system in the Isle of Man has dragged itself back to that position again.
I think that's an extreme view, and I think it's an unfortunate reference.
I just sound the alarm bells now seriously, because you can see it appearing before your eyes, and those who saw it happening then can see it happening again now.
Well, as I say, thank you for that. Your public is welcome to make any points that you wish. Other members of the public, yes.
Hello. Good afternoon. Nigel made a point which gave me a question to ask, and then Kate made a point which has made it a 2-parter. The first one is, 3 days ago in The Lancet, a new paper by a Dr. Gunther Kampf, which is titled "Stigmatizing the Unvaccinated is Unjustified," where basically vaccinee transmission between them is shown to be very high, not only in Germany but in America. So this might point to why Gibraltar at 100% vaccination is now having exponential rises in cases and hospitalizations, as is the Seychelles that never came off the red list, and also County Waterford. So the question is there any kind of review as to what's going on with especially let alone the ethics of mandatory vaccinations amongst care workers, because it seems a lot of jurisdictions are now moving a la Austria to like everybody. If that's the case, then perhaps there's a bit of a review needed. And then Kate brought up the point about care workers moving to the NHS at the time. But the question's not been asked why. And the possibility is that the yellow card system in the UK, the VAERS system in America, and the EU de vigilance system in Europe is not being talked about in terms of exponential rises in injuries and mortality amongst vaccinations. So there's obviously a reason why 103,000 people in the UK that work for the NHS don't want it either. But we don't seem to have that side of the debate as to why are they resistant. It's just a case of let's convince them. Whereas I'd like to ask the question, is there any kind of transparency about what's going on with vaccine mortality or injuries on the island if they're intercepted before they're put directly to the UK yellow card system?
You clearly know a lot about the subject, certainly a lot more than I do, but in my understanding, the questions you're asking really are about policy or public health, neither of which we are really equipped to answer you here, I'm afraid.
But you are on the ground. You're at the coalface, I think you mentioned.
I think in terms of your question, why do people not want to have vaccinations? Yes.
It's not being asked. It's not being in the media. It's not being asked at all as to why are they resistant. Because a lot of people have had them, myself included.
Yeah, sure. I mean, does anybody else want to come in on this one? I mean, because I know we've asked the same questions in other places, and people have needle phobia. They have concerns about the contents of the vaccine. They believe they've had the disease already, so why should they get vaccinated? They're probably
another natural immunity.
Yeah, sure. Does anybody want to add to this that knows more than I do? Sri.
So the first thing is that there are 2 parts to your question, isn't it? Why does actually people in UK don't have the vaccination at all? And how many, you asked, your question is about how many on the island don't have any vaccination?
No, what I'm getting at is if this paper and is being borne out by on-the-ground things like Gibraltar at 100% vaccination, and they're having big problems. If you compare it with Sweden, the graph is going like that for Gibraltar, and Sweden's down here if you look on our World in Data or Worldometers. My question is, why is there a talk about mandatory vaccinations if the countries that have had 100% take-up are having problems. Perhaps we need to have a review first.
So, as you know, we do not take up any policy that we want to actually kind of embrace it with what is UK. We have an active debate within our organisation anyway, with the public health and everything. It hasn't come up to that. We haven't gone to the vaccination board as yet. And after that, the clinical group will also meet to actually discuss about the pros and cons about vaccination. So that hasn't happened as yet.
But the mandation has. Yeah, and you said yourself the NHS in the UK is now mandating it. So you're kind of cart before the horse, aren't you?
And not necessarily. So there are lots of things about the same thing goes with the care home vaccinations. We did not kind of enforce the care home staff to have vaccinations. So that is quite actually contrary to what the UK position has been. Our vaccination position has been different.
But they're not saying anything about the Austrian situation. They're not denouncing it, which is worrying.
Correct. You're absolutely. There are lots of concerns there. We haven't actually come up to here to say that we are mandating whatever the UK says. We will have our own debate in our own bodies. And then I think your points would be right. Once we've actually made that as a policy, you might come back and ask us saying that how did you come to this conclusion and why are you implementing this policy without having a proper review? But at the moment, we haven't done that.
Prevention is always better than cure, so that's why I'm here now.
No, absolutely. But we haven't even come to the implementation of policy. But you're absolutely valid, and these points will be debated at all different groups and forums and panels we have. And then we'll, of course, absolutely at the right time, you may want to pose that question again.
Sure. And the transparency on the vaccine adverse events and mortality on the island, because at the moment I think they're being transferred directly to the UK side. But it doesn't seem that there's any sort of intervention, although obviously there must be some intervention. Somebody must know when they end up, unfortunately, getting processed.
Correct. All the yellow cards are being transferred to the UK, but they would know what's happened, what's the numbers in what we have.
But the accessibility to that seems difficult to the public.
Well, it's the way the system is set up, but I like to think that when you're actually implementing the policy, we will consider all the points that you've just made and come to that, and then you can actually ask about how did you come to that conclusion.
Can I,
thank you.
So thank you very much. I'm sorry we've got quite a long way over time. Was there any question you wanted to ask? No. Right, okay. Well, in that case, I'm going to declare the board meeting closed. Thank everybody for their attendance. I hope that we've done our best to answer the questions that you've given us. I think we've struggled a bit with some of the latter ones, as you can tell, but we'll keep trying. So thank you very much. Thank you.